Thank you, an ageing star. I also want to thank Professor Bonora for the invitation and Manuele for the kind introduction and everyone for being here so late. Immunotherapy in type 1 diabetes. Fiction. We don't do immunotherapy in type 1 diabetes in the sense that it's not mainstream as a therapy. And I think it should be mainstream. If we look at the natural history of type 1 diabetes, if we put this disease as, let's say, rheumatoid arthritis at clinical diabetes would be some severe deformity. It would be not full destruction of all the joints, but, quite a lot of it. And the difference is that we do treat much earlier in rheumatoid arthritis, and that's because of pain. But these conditions here, where we know that someone is going to go to insulin dependence and following that complications, we really, in rheumatoid arthritis, would be treating that with immune therapy. And I think that we have and must consider how to prevent that, what I would call close to end-stage disease. The these stages, we do go from genetic susceptibility to autoimmunity. There's a single antibody, the multiple antibody, which has also correlates in the pancreas, and which is called stage 1, a stage which is characterized by additional beta cell dysfunction, stage 2, and stage 3 is the clinical diabetes. This is more clearly said here, and we have been trying very hard to bring this into almost diagnostic categories for us. So multiple autoantibodies with normal glycemia is stage 1, multiple type 1 diabetes-associated antibodies with glucose intolerance or dysglycemia is stage 2, and this is what is stage 3, what we typically call type 1 diabetes by ADA or similar criteria. And I say that each stage should be preventable. This is what the stages look like in practice if you are able to follow children from birth or close to birth. And this is looking at antibodies. There are 4 antibodies here: the insulin, the GAD, the IA2, and zinc transporter 8. And in this particular child, a little bit before 2 years of age, we see the appearance or detection of insulin autoantibodies very quickly spreads to multiple, and this is classified as stage 1. There's 2 years of stage 1 in this child before there's also detectable abnormalities at the level of metabolism, glucose metabolism, and impaired glucose tolerance. Stage 2, and around 1.5 to 2 years at this before deemed by criteria such as OGTT to be a type 1 diabetic patient and starting insulin therapy. So that's in practice, and what we have to do is wait for that to happen rather than to treat. So we could have what I like to see would be a prevention path where we start to try and prevent the stage 1, prevent the development of the autoantibodies. We would then have intervention when they have this stage to prevent further stages, and that could be done at both stages. This is sort of my futuristic vision. So if I had to think, where would we like to be in 15, 20 years' time, where we could have from birth a path where we would intervene? And for me, it is, if this is the whole population that we're talking about, let's say in Italy, and these are those cases that will develop type 1 diabetes, and it may be by then 0.5% who will develop stage 1. We could genetically screen them, identify people, and if we had a successful therapy that we would be applying very early, and that was effective to remove 50% of the cases, we would be left with these. We could then screen children for autoantibodies, for example, and identify the remaining who are at stage 1. And if we had a successful therapy, that successful therapy might actually prevent going any further in another 50%. And they may stay at stage 1. These would then eventually develop dysglycemia if we follow them. And if we had a successful therapy at that stage, we might remove another 50%. So that from this many, we may have so many cases that we would have to treat with insulin. So I see it very much as a process of prevention. Okay, let's start at stage 1, immunotherapy to prevent stage 1. And we would need to identify genetically at-risk individuals. I'm going to introduce the TEDdy study. The TEDdy study has followed over 8,000 individuals. It's performed in several countries, and it intensively follows children from birth, genetically at-risk children, to look for environmental factors, genetic factors that may affect or influence the development of stage 1, stage 2 and stage 3 diabetes. As I said, it's followed over 8,000. These children have been selected mainly on HLA genetics, which is the major susceptibility set of genes, and also first-degree relatives. And until now, there are 469 who have developed stage 1 type 1 diabetes, and of those, 330 have developed stage 3. And the children are followed until 15 years of age. So when we look at the development of stage 1 in these children, and we have 4 different HLA, you can see that the HLA stratifies this risk, but at age 5 years, around 6% of the DR3-4 children have developed stage 1, and somewhere less than 4% of the DR4-4s have, etc. What we were able to do is we were able to take these groups here, so these sets of HLAs, and we were able to create a genetic risk score, and that combined, as you know, type 1 diabetes, like type 2 diabetes, has multiple genes across the genome that confer susceptibility, and we took 44 SNPs from 44 additional gene regions and created this score, and we were able to stratify the risk in these quite nicely. If you take the upper quartile of the risk score, we find children who have a 10% risk to develop stage 1 type 1 diabetes by age 5 years. So that set us up very nicely. It is great because not only can we identify these children with a quite elevated risk, 10% or more. Remember that the background risk of a population is 0.5 or less percent, so we're increasing 20 to 30-fold. Before we could only do it by family history. Now we also can do it in the general population. And by doing that, we can actually identify more than 25% of those who will develop stage 3. What we've done is we've taken this criteria and gone away and said, okay, let's put it into practice. And we created, Annette Ziegler, my wife, and I, plus John Todd, have created a platform for Europe. It's called GPAD, Global Platform for the Prevention of Autoimmune Diabetes. And it's about newborn screening for genetic risk. So there are, the countries involved are Germany, Poland, Sweden, Belgium, and the UK. And the aim of this is to screen broadly with a newborn screening program for type 1 diabetes risk. How we do that? We either use the existing blood spots that have been collected, or we collect additional blood spots done through consent. We've created a very cheap, high-throughput DNA extraction and genetic typing that does 47 SNPs, and from that we can get the relevant HLA plus all those others and create a score. And in little less than 2 years, we are now at 117,000 plus screened newborns and infants. And from those, based on the criteria I showed you before, we have identified 1.2% with elevated risk. And the frequency is different between Germany, Sweden, UK, for example. Sweden and UK have more of these infants. Why is it important to do it so early? It's important to do it so early because the autoimmunity, whether it be because of too much moisture in a house or so, happens very early in life. It happens at a peak age. The peak incidence age is around 1 year. This is data from Germany. This is data from the TEDdy study. So a lot of children are developing their autoimmunity in these first couple of years of life. And therefore, we have a window, really, to start our intervention, which is up to maximum 1 year. Otherwise, we're missing a lot of those cases. They already have started the disease and eventually will get diabetes. This is also very nice if you look at risk. So if you take these children in TEDdy with the high risk and you then look at those and say, okay, what's the risk if a child is 2 years of age and is negative at 2 years age? What's their 5-year risk thereafter? And if you do that at different ages throughout TEDdy, you see a very nice exponential decay in risk, which is interesting from a pathogenic viewpoint. Why is that? But it also says that by the time a child is going to school, their risk is much, much less than when they were born. A lot of that is gone. So if we want to prevent this stage 1, we have to go in very early in life. The other interesting thing about what appears is that there are different flavors of this autoimmunity. And there is a flavor that says insulin autoimmunity comes first, and others where the GAD antibodies appear first. And these very early cases are dominated by insulin. So insulin is the weak point in these children who develop autoantibodies early. Insulin as an antigen that they lose tolerance against. And that's probably also because it is a genetic, the insulin gene per se, and Alberto in his earlier times has shown very nicely a mechanism of why that might be through loss of tolerance in the thymus. There's also another interesting point around insulin. There's a wonderful model in life which is maternal type 1 diabetes. If we compare children who are born with a mother with type 1 diabetes or a father with type 1 diabetes, the risk in those born to a mother with type 1 diabetes is about half to develop stage 3. And you also see this beautiful lack of a peak here at age 1 year in children who are born to a mother of type 1 diabetes. And this is very much they fail to make those insulin autoantibodies. So somehow they're protected to make insulin autoantibodies. And if we think about mechanisms of tolerance, we know these children produce insulin very early in life, during gestation themselves as a response to the maternal hyperglycemia. And this high insulin, in fact, and proinsulin stays with these children over the first 3 to 6 months of life as well. So maybe there is some effect of having this extra insulin in circulation that is helping with a tolerance. And we actually do believe that, in fact, what's happening is some sort of both central and peripheral tolerance, in that the cells that potentially are against the insulin and proinsulin, the T cells against those, are less in children of mothers with type 1 diabetes than fathers. And Jan Knoop has done some studies on cord blood which suggest that that's true. So we think that there is a mechanism that is associated with exposure to insulin that may actually be beneficial in children who are genetically at risk to get type 1 diabetes. And we, some years ago, did a study, a dose study. We're trying to mimic that in some way. So how do you mimic increased insulin, exposure to insulin? And probably the safest way to do that is to give insulin orally to try and have the person's immune system see insulin every day in a context of safety, and therefore hopefully induce more regulation and or lower the risk that they will make a response to insulin. So we did the study. We did the study in children who were aged 2 to 7 years. They had a very high genetic risk, around 50%, and we were able to show that at a dose of 67.5 milligrams insulin per day, it's around 2,000 units, we were able to see some immune response to that was not the typical immune response of diabetes, but something that looked potentially regulatory. And so on the basis of that, we've actually gone away and started a phase 2B study using GPAD, the newborn screening, as our catchment, and we've included as our first trial the primary oral insulin trial, POINT. And it is a randomized controls trial with placebo, and the children receive insulin or placebo from age 4 to 6 months. So as soon as they introduce foods, they are put into this trial. They need to be genetically at risk to have that threshold above 10% based on a genetic risk score, and they're treated to age 3 years. The study is doing very well. It has been recruiting for a little over a year and a half. We have 384 babies who are in the study receiving insulin or placebo. The aim is to get to over 1,000, which we expect to be done in a little less than 2 years' time, and the study will be finished in 2025. What's nice about the study, and this really has been modelled on NPOD as much as possible, we said what we'd like to do, because we're collecting material from infants, small children, and this is rare, we've created a biomaterial biobank which is open for sharing to other investigators, and we have over 8,000 samples so far. Okay, so that's stage 1 in immunotherapy. Of course, you can envision all sorts of other things, dietary interventions, vaccines against enterovirus, etc., etc. But in immunotherapy, there isn't much more that we can do at the moment other than oral insulin. What do we do in children with stage 1? So first of all, we have to identify them. Who can tell me what that is? Right. If you fly into Venice at night with green-tinted glasses, that's what it looks like. Now, of course, you all know that looks just like islet cell antibodies, and Franco Batazzo, way back then, discovered them, and he always used to say, only Venetian could discover ICA. So that's what I grew into, and Franco was my mentor for many years, and also Emanuele's, and that's indeed where we met. The antibodies, the targets we know, I've mentioned them. There's insulin and pro-insulin. There's GAD65. These are the key early targets. There's also other ones, IA2, which is really an important one, because if a child develops that one, they tend to go to diabetes almost certainly and relatively quickly, zinc transporter 8 and some other less frequent ones. What Alberto told you before, this is key. So why do we go stage 1 being multiple antibodies? Because if a child develops multiple antibodies, they will develop type 1 diabetes, stage 3. So this is follow-up up to nearly 20 years in these cohorts that have been started back in the late 80s, 90s, where children have been followed from birth, and you can see that, and the 1 antibodies are less. What is also important is that when you look at that from Teddy, it's not just those who have a family history who progress. So as long as you have the multiple antibody stage, you do not need to have a relative. You can just be in the general population. You will also progress to type 1 diabetes. So in reality, we could screen for antibodies in the general population of children and identify people who are going to get stage 3. And in fact, that's what Annetta and I started and have done in Bavaria. This is a rather ambitious program, really, of Annetta's, where she has taken the whole of the Bavaria, engaged the pediatricians to consent and take blood at baby visits at age 2 that occur between ages 2 and 5 years. It's done with capillary blood, and we created a very simple screening test, which is extremely cheap for us, where we can look and exclude the majority of these, and then if any of those are positive in this test, we go on and measure the rest of the antibodies to identify those that have multiple antibodies, confirm it with a second sample, and then diagnose this stage 1. It's been done now in 100,000 children, which is very impressive. The frequency of multiple antibodies in this is 0.3%. So 0.3% of the children out there would be diagnosed with stage 1 type, with multiple antibodies. Of those, they go through a metabolic staging, so they come to a centre and they get metabolic tested, OGTTs, etc. And of those, 81% have stage 1, 8% stage 2, and 11% undiagnosed stage 3. So by OGTT, they're stage 3. Asymptomatic, which is important, so they didn't know beforehand. So this is our way of identifying children on a large scale. It is popular now. Frida has become Frida Plus. There's Fridolin, which is done in another part of Germany, where they also do familial hypercholesterolemia as screening. There's the ASK autoimmunity screening for kids done in Colorado now, where they also do celiac antibodies, and we get requests every week from different sites who would like to start screening in the world. So we think that it's going to be the method to do, and we're also very strong in trying to get insurance companies and government to take this on in a reasonable manner. What do you do with them? There isn't much in immunotherapy that we are allowed to do in them. So I can tell you that trials that are immune therapy trials that are out there for autoantibody positive, and not all of them are available for children. So TrialNet, which is a very large organisation based in the USA, but also several European countries and Australia are involved in that. They currently have abatacept, which is CTLA-4 Ig. It's an immunotherapy. It, in fact, works by increasing negative regulation on T cells. It is actually doing the opposite of what you know in cancer therapy as checkpoint inhibitors, which increase the regulation. So the checkpoint inhibitors decrease the regulation to allow T cells to kill off the tumour cells. Here, the therapy is doing the opposite of that. So that's available, and there is a trial. There's a newish trial available, which is hydrochloroquine. Those of you who may know it as an antimalarial. It is a very common antimalarial drug, but it's also used in some cases for rheumatoid arthritis and lupus. It reduces antigen presentation by dendritic cells, so the innate immune side, addressing that in terms of activating the T cells. So these are available, but they don't go down, at least in Germany, to 2 to 5-year-olds that we identify. We cannot give them to 2 to 5-year-olds. In Germany, the Frida study is doing oral insulin because it can, and it's a mechanistic study. Sweden is also doing GAD65, another antigen vaccination with alum adjuvant. But there really isn't much else at that stage. There is now, and this is the breakthrough, I think, at stage 2 type 1 diabetes. And this really was presented at the ADA. It was published in the New England Journal of Medicine in June, and it was also presented at the EASD by Kevin Errold, who was the study chair. And it is the anti-CD3 teplizumab. So anti-CD3 has been around for a very long time, in fact, from mouse studies in the very early 90s, and we are now 2019. Okay, so it's a long time. There were a number of studies done which showed some efficacy in patients at stage 3, and based on this, TrialNet actually designed a study to try and put it into stage 2. And they did that, and they randomized 76 stage 2 diabetes patients into treatment arm or placebo arm. And the treatment is 14 days. It's not a very high dose. It's an IV treatment, but they have to stay or be close to a clinic or hospital to have that treatment. And this is the outcome. It was exciting for us because it's the first time we've ever seen in a prevention study in type 1 diabetes this sort of difference. This is the placebo. This is progression to diabetes. This is 5 years here to stage 3 diabetes. This is in the treatment arm. So you can see that the delay is very significant. It's an adjusted hazard ratio of 0.41, and it's a delay of at least 2 years, a little over 2 years to the stage 3. And this indeed was exciting. Of course, anti-CD3 people often ask, yes, what are the side effects? There are side effects as compared to placebo. They were not higher in this study than grade 3, but there were considerably more grade 3 in the treatment arm than in the placebo arm. The ones that are there, if you can read it, are, of course, blood, bone marrow, and that's because anti-CD3 removes CD3 T cells from the blood transiently, and therefore you have low counts, and that's something you will see in the majority of patients. And also some skin adverse events in the treatment group. This is the blood counts. You see the blood counts come down. This is the treatment time, and they're already going up. So it's a transient loss of lymphocyte count. This is exciting, and Prevention Bio, who owns this, have received breakthrough therapy designation in the USA for the teplizumab anti-CD3, and is seeking the equivalent, which is PRIME designation, in Europe. And this allows this to take priority and move forward. And one of the things that they're trying to do is, as priorities, is to redose, combine, but also in children below 8 years. These studies in the past have always been done between 8 and 17 years, not below, for various reasons that you can imagine. However, I told you, these children with antibodies are developing them early. So when we treat out here, many of these have already got diabetes. What we're treating out there are the ones that are surviving that, okay? So, and you can see this here, what happens in children who develop the autoantibodies, each year they have a risk of 10% to progressing to stage 3, okay? So this is something that is important. If you want to start really treating these with such drugs and preventing stage 3, we need to go earlier than age 8 years. The other aspect here of this study was that it took 6 years to recruit 76. And this is with a network that is phenomenally large, okay? So, and this is targeting relatives. So again, the change that's being brought about by studies like FRIDA, where we're screening the general population, FRIDA could have recruited those in Bavaria in a similar amount of time, just in Bavaria, okay? So you can imagine doing that in multiple places. You will be able to do these trials far more quickly. What else is on the horizon to prevent stage 3? Well, I know that TrialNet at least is discussing other agents that have been shown to work to preserve C-peptide in people with stage 3 diabetes, so the so-called new onset trials. And 2 in discussion are low-dose antithymocyte globulin, and it is the one in blue here for C-peptide. Placebo is in red, so that preserves C-peptide for 2 years out above placebo in new onset trials, and this is and also with an associated lower HbA1c. Something similar for 12 months here reported many years ago for rituximab, which is anti-CD20, and they are also considering these. There are other immune therapies that are out there that are being done and tried in new onsets. The IL-2 study is a very good example that's being done, and we hope that the more of those will be successful, the more we can go back into earlier parts of the disease. That's the thank you slide. I do have a lot of collaborators and a lot of funders through Teddy, through TrialNet, through our institutes in Munich and in Dresden, and the GPAD group, which is extremely active, collegial, and effective in their screening, and the usual funders. Thank you very much for your attention. Happy to answer questions.
Thank you, Ezio. Impressive, as always. Open to questions, comments, even criticisms.
Never. Never a criticism. I can start. So there was a question. Okay, Abata, you can have the question.
Thank you, Ezio. I think a point that might be worth discussing is the fact that many of these therapies that you've shown, they have a temporary effect. They delay destruction, but you see the curves, the C-peptide keeps going down. So now, many of these things, I don't know how easy it is going to be to redose in children and for how long. So we mentioned IL-2, there could be many other things that one can think of as maybe a maintenance therapy that helps regulate and in the long run prevents the disease from coming back. And we know that even in the transplant patients with chronic immunosuppression that prevents rejection, it can come back. So that's a tough one, but I think for the clinicians in the audience, how do they visualize, how are we going to translate these therapies into something that people take and really works?
Yep. So two responses to that. So within the anti-CD3 trial, the teplizumab trial, there's always people who respond and people who don't respond. The responders tend to be longer in how they have longer than the time that they've not developed type 1 diabetes or stage 3 diabetes. So there may be some individuals in there who have, it's been prevented. There may be, okay, lifelong. Generally, we look at that and we think, okay, we need to give it again a second dose. It's at 12, after 12 months. And then the question is, well, how long do we have to do this? For sure. So is this inducing something that has a regulatory function that is lifelong or not? And is it doing it in which patients and which not? And these are aspects that need to be tackled with respect to biomarkers. In a patient with rheumatoid arthritis, they're treated immunotherapy lifelong. And we need to see whether we think the safety aspects, whether the drugs are going to be better from a safety aspect in the future, for sure. In response to the second part, yes, I think we should be looking for agents that induce long-term tolerance. I have difficulty when there's an immune response that's ongoing, and where Alberto can also see if he transplants a patient or that someone transplants a patient with a pancreas, many years later, you can see the autoimmunity coming back and destroying that even under immunosuppression. So I think once you have this memory response, it's there to control. It's difficult to switch off completely. It may be done in some people. It's why we do the primary in the hope that we can stop it from starting.
Professor Muggeo, first row.
Thank you, Ezio, for the beautiful presentation. I'm old enough to remember the story of a cyclosporin. So, in your scheme today, how do you put cyclosporin attempt to do the same?
It would. Cyclosporin would actually work. No question, it did. All right? It's got a bad name, so you don't do it. And it also causes some complications, which Professor Grupp will also say to kidney, etc. So we don't do cyclosporin. It does work. So do many other immunosuppressive drugs will work for sure. Cyclosporin was probably the most effective immune therapy we had in type 1 diabetes. And there are some others that people talk about with bone marrow depletion and then reconstitution, and that's probably as severe as giving cyclosporin. So it asks the question, should we use immunosuppression? And as a rule, we've said no. We need to do something else. I think if we have safe immunomodulation, then we change the word to immunomodulation rather than immunosuppression, we could probably get away with it. But it's good that you bring it up, because cyclosporin is probably still the most effective drug we've had.
In your scheme,
it would only come...
Where would it put?
Cyclosporin would come, if something like that, it really would be where I showed the anti-CD3. So at that point, preventing the progression to insulin requirement, stage 3.
In fact, my point is, cyclosporin was never used in the phase 1 or 2.
Right. No, and I think phase 1, so it would, stage 2 is where I would say it would go in. Stage 1, definitely not. And there it really also is important to see the studies coming from NPOD where it looks like there isn't much happening in that stage. We have to wait until we see true metabolic dysfunction, which means the joints are starting to break up. Thank you.
Bonora, then Doctor.
Thanks a lot. Very, very nice talk. There was a paper published, I think, 2 or 3 months ago on the New England about just an observational study in which it was noticed in the U.S. that after they introduced the vaccination against rotavirus, there was a very impressive reduction in the incidence of type 1 diabetes, at least impressive to me.
It was JAMA.
I'm not an expert.
It was JAMA.
Okay, JAMA, perhaps.
Yeah, it was JAMA for pediatrics maybe, but JAMA. And it was a lot of discussion about it. There's also, it's very hard to do the proper study, to introduce a vaccine to see whether it reduces, because you can never properly control it with placebo unless you plan the study right away. So this was a time thing. Diabetes incidence was like this. They introduced rotavirus. It went down like that. Okay, so that's the positive aspect of that. There are a few others that are coming out from the US that are not reporting something similar, but the numbers are questionable. There was a study in Finland that also says it's not quite like that. But yes, I think that could very well be, whether it's rotavirus it causes some damage at the beta cell, or it changes the immune system, and we can avoid that. I don't know the mechanism. What we'll find, because rotavirus is being introduced everywhere in Europe now, is that we won't get much rotavirus infection anymore, and we'll see if there's an association with a lower risk. I don't think we'll ever be able to prove it. But if it does, it's good, because it's there now.
Francesco.
It was an Australian study, I know. The JAMA one is an Australian one, yes. Yeah, no, so there's an Australian one, which is the first one that's published. There's an American one that also shows it. There are a couple of other American ones that haven't been published yet. And there's the Finnish one that doesn't.
Anna Solini, please.
Truly wonderful talk to my eyes. I was really impressed by the huge difference in the risk to develop overt type 1 according to the presence in the phase 2 of 1 rather than 2 or 3 autoantibodies, with no difference between 2 or 3. So my naive question is there any possibility to pick up in the phenotype of those children that face any other characteristic or biochemical parameter related to the number of the autoantibodies and therefore to the risk to develop?
So I can say that there are certain characteristics of the antibody that goes with that?
No. Is there any different characteristic in the phenotype in that phase, in that phase 1, according or related to the number of the autoantibodies?
No, biochemically, not that I know of. Sometimes the antibodies themselves, the single ones that stay single, they have some of them have a different target on the antigen, so they react with a different part of the molecule, or their affinity is not super strong, so they're not quite the real full antibody, and they stay single. Some of them. But I haven't seen any biochemical parameters that are different or change, no.
Grazie, it's a beautiful presentation. Actually, my question is some kind of comment reflects both presentations. From what we heard from Alberto and from what we heard from you, I understand that there is a great deal of heterogeneity among patients that for me is responsible for the long track of failures in terms of clinical trials in preventing diabetes so far. So the question I have, I think that we should try to stratify as much as possible our patients before entering them into trials and towards some kind of personalized approach. So I'm curious to know what you think about this.
It's a very topical discussion point, and we know very well how wonderful it's been done in type 2 diabetes. In type 1 diabetes, of course, we know that age is a critical factor of what that disease looks like, and I think you're right about the precision aspect of it in terms of some therapies may be more effective in this than the other. What I would be cautious about is to state that these are very different forms of the disease or the pathogenics, because I think it may be true, may very well true, but a 2-year-old and a 16-year-old, their immune system is so different, and they're at so different stages that it just has to be also, it may be a same process, just taking much longer, but the immune system the process is the same, but the immune system is just at a different stage. So I think physiology may be part of the heterogeneity, and we're over-interpreting pathogenesis sometimes. So I put a caution into that. But I think you're right. I think that there's clear different losses in C-peptide if you're 30 when you get diabetes and if you're 3 when you get type 1 diabetes. And Alberto can back it up, I think. Very good point. This is why we stay on children as much as possible, because if you get on it's too difficult.
Stefan.
I'd like to congratulate both of the speakers. It is very illuminating for someone who is not really very much involved in type 1 diabetes. You have been discussing a lot about the autoimmunity and the degree of the level of the expression of that autoimmunity. There's been a very recent review on Nature Endocrinology reviews on type 1 diabetes. And one of the things that really struck me is that the incidence of type 1 diabetes is increasing irrespective of the starting point you are in. It doesn't matter if you're in Finland, if you're in Taiwan, okay, there is still a constant increase in the incidence. And they also have a very nice graph showing how much is the effect of the environmental factors. So my question is, yes, you guys are spending a lot of effort in the predisposition of the individual, but what about ranking the triggering factors? There was something now you've been discussing before about rotavirus. Pera was mentioning some of the ambient air that people are exposed to. But what are we standing with that? And how much do you see the combination of factors that could modulate the autoimmunity, and also in identifying the different degree of factors that can really trigger the condition?
So, I mean, I have some personal opinions on that. I know Pierre's going to say something about the fact that it's flattened out in Finland, and this is climate change for sure, because it's getting warmer there. Joking. So, obviously, environment is very important. And what I think, and, we have this peak incidence around this 1 year point. Not entirely sure it's a trigger. I think that there's perhaps something that's triggering the autoimmunity. I mean, maybe there's a trigger in stage 3. But I think that there's whatever's going on in around the first year of life, whatever that period is having this susceptibility there, and it needs to involve the beta cell. Because the same children are at risk for developing thyroid immunity. They have the similar genetics, but they develop that in their teenage years. Celiac, age 2 years. So I think the target organ and whatever's happening there, could be a virus, could be the feeding, changing of the beta cell, remodeling, etc., is doing something there. And obviously the environment, and it could be toxins, absolutely, is really having an important effect. There's no question about that. And especially also in the fact that we're seeing it in less genetically susceptible infants as well. So the penetrance of the disease is being increased by the environment. Other people will tell you it's because of what we've taken away, because we're cleaner now, etc. So we should put something back in. Don't know. I know that you wanted to say something to that. Is that right? No. Okay. Alberto?
Excellent. This is really the big question. Last, please.
I just want to ask me to comment. So it's a valid point. I don't know that we really can call something a trigger for sure. And even when we talk about viruses, for example, we have indirect evidence, not direct evidence that they are the trigger of autoimmunity. They can do a lot of different things. When we think about enteroviruses, we don't think of a classic acute cytotoxic infection. We have no evidence when we look in these pancreases that there is a massive and cytopathic infection. I had limited number of slides that I could show, but one slide that I use shows a massive infection of islets in the pancreas where all the cells are stained for VP1. And then what we see in type 1 diabetes, where only few cells are stained. So the type of infection that we're getting is maybe not conventional. And so the mechanism by which these viruses may be triggers is not canonical. Now, to prove this, maybe we need to have vaccines. And so what we're getting with our virus data, if they're true, it's actually very encouraging, because that's the kind of data we would love to have for enteroviruses. But we don't have a vaccine yet. However, it is being made. So probably in the next few years, we'll be able to start a trial for that. There is a new onset study, which is going to use, it started already, a combination of antiviral drugs to try to interfere with a viral infection, which presumably may be present also at the time of diagnosis. And if, in fact, the viruses could impair beta cell function, then you would expect that by using antivirals, you could improve beta cell function, you might reduce inflammation caused by the virus, and you may tone down autoimmunity. So ultimately, you should see preservation or improvement of beta cell function. So we'll know that probably in a couple of years. But we need to have proof that something does something. For the T cells, we have a better idea of that. For the viruses, it remains a little bit unproven, although I think there is a lot of evidence that at the end of the day, they are in there. But I don't think that we've looked at all the ones that could possibly be involved. It could be more than one trigger. Yeah, so It's not simple.
And so Coxsackie infections, I believe, in Finnish children is less frequent than in German children, at least from antibodies. So, but there may be other reasons there. They're not protected because of maternal protection. There's so much to